Hello, I'm Stephanie Valent, an M3 medical student at Quinnipiac University.
And I am Jocelyn Miller, a third year emergency medicine resident at the University of Connecticut. Today, we will be discussing workplace violence.
All of us have different experiences in the ED, whether we have worked in trauma centers, community hospitals, or rural centers. This presentation will serve as an overview to contextualize some of the shared challenges common to many emergency departments. We will provide some definitions, including legal terminology, data regarding prevalence, and finally, the tools available to help us promote a safe work environment. Why do we do what we do? Of course, we have a unique opportunity to intervene and help our critically ill patients. We get to see a vast array of chief complaints and perform countless procedures. But one of the best parts about working in the emergency department is the uniquely close team we form with our colleagues. We work side by side with our fellow physicians, nurses, technicians, and other team members we will come to know well and rely on. As leaders, we come to feel responsible for the safety of our coworkers. The strength and endurance of a company does not come from products or services, but how well the people pull together. Every member of the group plays a role in maintaining the circle of safety, and it is the leader's role to ensure that they do. This is the primary role of leadership, to look out for those inside their circle, says Simon Sinek in the 2019 book Leaders Eat Last. Workplace violence in the ED has come to the forefront of the media in recent years with the 2016 publication of the United States Government Accountability Office Workplace Safety and Health Report that brought to light the prevalence of these incidents in the healthcare setting. The Workplace Violence Prevention for Healthcare and Social Service Workers Act has passed the House of Representatives 254 to 166. This bill requires hospitals to maintain workplace violence prevention plans. Some states, including California, Connecticut, Maryland, New Jersey, New York, Oregon, and Washington, already require this. If you are early in your career, you might wonder how this will affect you. As you progress, you may be directly involved through leadership and committee memberships designed to promote a culture of safety to protect you and your team members. In a 2016 New England Journal of Medicine article entitled Workplace Violence Against Healthcare Workers in the United States, Dr. Phillips outlines types of workplace violence in respect to the relationship between perpetrator and victim. Factors contributing to patient-perpetrated violence include mental health issues, medication withdrawal, illicit substance use, and dissatisfaction with care. The pervasiveness of these issues in the ED places us at increased risk for type 2 violence. The National Institute for Occupational Safety and Health defined workplace violence as the act or threat of violence ranging from verbal abuse to physical assaults directed towards persons at work or on duty. Depending on your experiences, you may have already witnessed incidents of violence. We take care of people at their most vulnerable. We take care of people under the influence of alcohol, cocaine, PCP, and other intoxicants. We take care of good people on their worst day, and sometimes they do not possess the coping skills to behave in a manner that truly reflects who they are. There are different methods of workplace violence categorization. Workplace violence is often categorized as physical or verbal. Interestingly here, Copeland and Henry have also included threats of lawsuit under verbal violence.
Acting in the best interests of the patient should always be in the forefront of healthcare providers' minds, but we don't want to be harmed in the process. One of the best protections employers can offer their workers is to establish a zero tolerance policy toward workplace violence. The 2016 Workplace Safety and Health Report to Congress did show that non-fatal workplace violence injuries occurs at a rate 5 to 12 times that of non-healthcare workers. Prior investigations revealed that 1 in 4 EM physicians had reported being the victim of physical violence within a single year. In the first prospective study to identify incidents of violence in ED employees, Kowalenko et al. Surveyed 2013 ED workers monthly. 827 violent events were reported over a 9-month period. The violent events reported were translated to number of events per person per month in order to compare across professions. Physicians experienced violence at a rate of 0.28 events per person per month. Interestingly, RNs reported a significantly increased rate of violence. Copeland and Henry in 2017 published a cross-sectional study in which they surveyed ED staff members in a Level 1 trauma center regarding their exposure to workplace violence. Out of 147 respondents, 88% reported experiencing verbal or physical exposure in the preceding 6 months. Factors associated with greater exposure included night shift work, less experience, and psychiatric healthcare work. The Joint Commission has an open source compendium of resources to help promote a culture of safety. This includes resources on prevention, data collection, and training resources. The American Association for Emergency Psychiatry worked with EM psychiatrists, EM physicians, and other healthcare team members to create guidelines for verbal de-escalation. Team steps, team strategies, and tools to enhance performance and patient safety is another commonly used model for improving communication and safety. Elements of this program include extensive communication and collaboration outlined in an easy-to-use format. It incorporates interdisciplinary communication as well. CPI, Crisis Prevention Institute, training is another widely used tool for nonviolent crisis intervention. They provide training for many different disciplines. Where we worked in the past, ED staff had this training annually. While these recommendations may seem intuitive, having a methodical approach to rely on times of crisis can be invaluable. One of the challenges in evaluating efficacy of mitigation strategies is the difficulty obtaining incidence and prevalence data in a culture where we often feel such a strong sense of duty to care that we may not report all incidents. When patients are the perpetrators of violence, elements of empathy and duty to care for others may convolute the victim's perception of the event. In the USGAO Workplace Safety and Health Report to Congress in 2016, it identified very low reporting rates from 7 to 42%. Factors contributing to underreporting these incidents include inconvenience, the perception that violence comes with the job, and lack of injury. In order to strengthen efforts to mitigate the environment, it is important to contribute to a culture where colleagues feel empowered to report these incidents. If you listen to this presentation and have found yourself thinking about what actions can you take next, here's a list of the resources for quick reference. The Joint Commission Compendium is an excellent resource with an abundance of material. Steps 2.0 gives you a framework for incorporating this lesson into your future curriculum. And the Crisis Prevention Institute gives you helpful reminders on the tools we as providers can use for de-escalation. Despite the challenges of emergency medicine, Medscape EM Physician Compensation Report from 2021 showed that 73% of EM physicians would choose EM again. This is only slightly decreased from Zydolka and Corte's finding that 77.4% of EM physicians found the specialty met their expectations in 2004. As leaders, it is important to become familiar with the violence mitigation resources at one's institution, as physicians help establish a culture of what is to be expected and how to manage situations when they arise.
Thank you for joining us for this important topic. We hope you find the resources helpful.